Good morning, dear friends. Today I am going to tell you a very rare condition of the spine, total dislocation of L3-4. It is also known as spondyloptosis. A case report, a very rare entity. Dislocations of mid-lumbar vertebrae are exceptional and results in unstable spine, deformity and spinal canal deformation which lead to severe spinal cord injury. To the best of authors' knowledge, only 16 mid-lumbar spondyloptosis have been described previously by now, and all previously reported cases were treated surgically. This is the review literature. Mid-lumbar traumatic spondyloptosis without neurological deficit. A case was reported by Zhu Feng in 2020 March and published in volume 99. I am declaring about my patient, male aged 40 years. We present a case report of L3-4 dislocation with neurological deficit resulting from crash of motor lifting tripod falling on the patient's head. The anatomico-pathological mechanism of injury is discussed together with the treatment, which consists of initial close reduction, failed but successful open reduction and fixation. Long construct of pedicle instrumentation and arthrosis was a successful surgery for the result of the patient. This was a case of high impact energy trauma. Patient was admitted with severe back pain, spinal deformity and neurological deficit of both the lower limbs, was in spinal shock and oxygen level and breathing was compromised and was admitted in ICU in emergency. This was the immediate X-ray following injury, which shows there is total dislocation of L3 vertebral body over L4. There is no contact in AP and lateral view, and this is a very rare injury we faced. This is the MRI picture, which again shows there is total dislocation of L3 over L4 and the cord is totally disrupted at L3-4 level. Patient also had a long spiral comminuted fracture femur upper third shaft on the right side and making the treatment complicated. In stage 1, he was operated for close reduction of L4, operated for fracture femur, open reduction was done. This was the post-operative X-ray. Patient was operated for spine surgery. This was a miraculous marathon surgery where the dislocation of L3, L4 was completely reduced and the fixation was done by a very long implant from L1 to S1. Surgery was very difficult. Reduction of complete dislocation, how to do it was again a dilemma. Technique of reduction was mechanical and we learned out of box thinking case. How to pass screw while getting reduced at L3-4 level was very difficult because of the unstable spine, and fixation of a very long segment from L1 to S1 is again a marathon job. Passing screws and pedicle roll fixation equally difficult proposition in this particular. At the end of the 6 weeks, patient started walking with calipre and walker. His urine and stool control achieved and patient was very happy. Patient underwent Fracture open reduction L3 for intervertebral fusion, internal fixation using long construct of pedicle instrumentation. Patient was pain-free and fully rehabilitated 3 months after the surgery. His neurological status improved from 0-1 to grade 2 to 3. Bowel bladder recovered completely normal. After 1 year follow-up, the patient had pain-free back with stable normal alignment. This helped in neurological recovery and was rehabilitated with assisted calipre walking. So many difficulties were predicted. Some of them are reducing the dislocation and maintaining the dislocation while passing the pedicle screw in the proximal segment, as with the slightest anterior force to introduce pedicle and awl and probe, it will slip forward, and due to lack of the counter force, it becomes difficult to pass screws in the proximal vertebrae. Reduction was done using and levering L3 vertebra by bone spikes supporting the proximal segment. Long segment multiple 6 screw fixation on either side is also a difficult proposition. Traumatic spondyloptosis is a rare fracture related to high energy impact and usually leads to devastating clinical consequences, and the neurological recovery is very unusual. Restoring stability and preventing secondary cord injuries should be taken into consideration for better rehabilitation and neurological recovery irrespective of severity of impact and injury grade. This was the poster prepared for this presentation at national and international level in the spinal conference. Thank you all for kind listening. I am Dr. Purohit, Senior Orthopedic and Spine Surgeon from Khet Hospital, Ahmedabad. धन्यवाद. जय हिंद. जय